is the provincial geriatric team here today. 3 of them are going to speak on the topic of critical conversations. And then everyone's going to be involved in helping facilitate our learning collaborative groups today. So I'd like to introduce Shandra first, who is the team's psychologist. She's over 15 years of experience as a physiotherapist in a variety of clinical settings. Within the field of obesity management, she's held positions with the Edmonton Weight-Wise Adult Community Team and the Edmonton Adult Bariatric Specialty Clinic. In her role as chair of Alberta's Health Services Provincial Edmonton Eating Working Group, and she's also one of 4 level 2 certified teachers of the health change approach in Alberta. I'd also like to introduce Pam, who's an occupational therapist with the Provincial Bariatric Resource Team. And she's worked in an adult bariatric specialty clinic to help enable people with obesity to engage in their occupations of daily living. She also has experience working in acute care and teaching occupational therapy and health science to students at the University of Alberta. And then lastly is Carlene, who's also going to be speaking today. She's a registered dietitian with the team and also the provincial program lead obesity and nutritional services. Carlene has 15 years of experience with Alberta Health Services. She's a passion for adult bariatric care specifically. And in addition to 10 years with counseling clients in adult bariatric specialty clinic, her contributions have definitely helped develop evidence-based guidelines, publications, workshops, and patient education resources to help both providers and patients improve their health and improve their weight. So these 3 are going to present most of the topic, I think, and then they'll introduce the rest of the team as the day goes on. Any questions? Great, let's introduce the team.
Thank you for that lovely introduction, Jody. Although just a point of clarification, although I've often perhaps aspired at times to conduct physiotherapy, my background is actually in psychotherapy. And so just let me jump in by saying how pleased we are to be invited here today to present to you. And really our hope for the presentation today is that it's an opportunity to generate some dialogue and some discussion. Certainly acknowledge that there's a wealth of expertise and experience of everyone in the room today, and so really look forward to hearing about some of your experiences again when having those critical conversations. So to talk a little bit about our team, so the Provincial Bariatric Resource Team. We act as a support or resource for healthcare providers working in the area of obesity or bariatric medicine. We're a multidisciplinary team, and so we're made up of 7 clinicians. There's 2 psychologists on the team. I represent adult populations. My colleague, Damien Sarnecki, who's not with us today, represents pediatric populations. He's on leave right now. Otherwise, we have pretty much a full contingent here. So we have 2 clinical nurse specialists, Heather Ebling, representing adult populations, and Joy Mekachuk, representing pediatrics. Cindy Grant is the physiotherapist on our team. And you've already met Pam and Carlene, and also our director is with us today, Tim Barron. And so he's the Director of Provincial Chronic Disease Management Programs. So our team is involved in education for healthcare providers. So we deliver provider education right across Alberta. We work with knowledge translation, so to look at the evidence or literature and translating that, supporting clinicians to translate that into clinical practice. The opportunity for best practice or consensus building with clinicians provincially. Some of that involves identifying gaps that might be present, creating linkages and the development of resources, not only for providers like yourself, but also for patients. And we also run a consult service, so I just want to draw your attention to that. You'll see on the handouts that you have and at the bottom of the slide our email address. It's a little bit long, but it's essentially Provincial Bariatric Resource Team at albertahealthservices.ca. And so that's intended to be an opportunity for providers to ask any questions or explore any issues. And so feel free, if something comes up after we're done our time here with you today, to send us a question to the provincial email address. So a bit of agenda for our time together today in exploring critical conversations. We're first going to look at, in a moment, I'm going to talk a little bit about communication within the context of a change-based or therapeutic relationship. Then I'm going to turn it over to Carlene, who's going to explore within that some conversations around weight. And Pam then is going to wrap things up by looking at potential barriers that patients may face and how that potentially can impact on behavior change. So I'll just give you a moment to kind of reflect on the quote there. So coming together is the beginning. Keeping together is happy. Progress and working together is success. So I'd ask you just for a moment to reflect on perhaps a critical conversation that you might have had at some point recently with a patient that you saw for the first time. And as we go through today, thinking also about what worked well in some of those critical conversations and what you found may have held you back or where you may have run into some difficulties. When you typically, in a first or initial consult with a patient, what are one or two of the first questions you might ask? Does anything come to mind? Think back to your last first visit with a patient.
What brings you here today?
What brings you here today? Great, nice open-ended question. Then, where would we traditionally go from there? Any ideas? So it's great to hear that the first inclination, it sounds like you guys are already ahead of the curve in the idea being that you're looking at that open approach, so allowing the patient to bring their experience forward. And what do you think the impact of that might be on the relationship that you develop with your patients?
You start to develop some more rapport.
Yeah.
So, I mean, it's all about relationship.
Great. Makes sense.
Especially if I'm here.
So looking at some of the evidence base that's come out of the field of psychotherapy, and this is a lot of the research has taken place within the context of psychotherapeutic relationships, but it also carries through and holds true in other areas as well. So there's also research that's been done within the field of nursing and healthcare as well, looking at, so across studies, the largest portion of outcome variance that's not attributable to pre-existing client conditions as actually from the emergent therapeutic relationship between client and clinician, regardless of the technique that's used. So what that tells us is that unless that strong foundation is there for a relationship, no matter what we're doing, that foundation needs to be established in order to support the clinical treatment that takes place. So if you think of it kind of like building a house, you need to have a solid foundation in order to put that frame up. So it should come as no surprise then that the heart of successful communication is not only stating information or what is said, but it's the art of conveying that information or expertise in a way that allows our patients to feel heard, understood, and respected. So to create that atmosphere of safety and trust in which they can feel free to talk about what might be working well for them, knowing that they're looking at making long-term sustainable changes to support healthy lifestyle and manage chronic conditions such as weight or obesity, but also to look at within that what things may not be working well for them. So to express some vulnerability, to bring forward the idea and discuss with you not only what's working well, but where they're experiencing some challenges or struggles. So what the research tells us around therapeutic relationships and what works. So the idea of accurate empathy, no surprises there. And this information is likely you're already familiar with, but just an opportunity to kind of touch base and reflect on some of what we know from the literature works. So alliance, and so the alliance is composed of 3 elements. So that's the bond that you establish with your patients or clients. It's also the therapeutic or treatment tasks that are identified, and goals consensus. And so goal consensus or collaboration looks at, this is kind of the idea that we're in this together. Okay, so I'm here to support you in your journey in this process as a clinician. Unconditional positive regard, so you're likely familiar with that terminology as well. So this is the inherent sense of value that we have for the worth of that person, that human being that's sitting across from us. And as distinguished from, so that means we can support and inherently see the worth or their humanity, but doesn't necessarily mean that we're accepting of all behaviors within that. So distinguishing the personhood from the behavior. Genuineness, or sometimes this is called congruence. So this is the idea that even within the context of a relationship, people get it, and we're not, when there isn't that sense of genuineness in the approach that we're taking. Feedback, so this is, if you have a strong alliance or a therapeutic relationship with an individual, there's that opportunity to also provide them with feedback about what's working well, what you're noticing in their behavior, and potentially point out some incongruencies that you might be noticing. So you know what, I hear that you really value this. This is what you're really wanting to accomplish, but at the same time, this is what I'm noticing with your behavior, and it doesn't really fit. What do you think about that? So to have that open, honest dialogue. Recognition and repair of what we call alliance strain or rupture. So this is when there's a problem, when something's off, it's not going well. And if a patient or an individual brings forward a concern about that, and it's responded to appropriately in a responsive way with non-judgment or non-defensiveness, not being defensive, it actually can enhance or strengthen the alliance. Now, hopefully, those ruptures are things that are identified by the patient. They always have the opportunity of what we call, sometimes I call voting with their feet. And so, of course, those are the individuals who just don't come back to see us, and no-show for appointments. And so, hopefully, there is enough of a solid base in that alliance or bond that they actually feel comfortable sharing those things that they're unhappy with, because the reality is that comes up. It's really a common occurrence. Are you familiar with motivational engineering? Is that, okay, I'm seeing a lot of nodding heads. Great, okay, so I won't go into too much detail. But essentially, when you look at applying motivational interviewing to a healthcare context, so this comes from the work that Bill Miller, Rolnick, and Butler have looked at. A really wonderful resource if you're interested in more information, motivational interviewing in healthcare. So they talk about 3 styles of communication that need to be matched to task. So depending on the context you're working with an individual in. So that might be following. So that's kind of this open-ended, general, non-directive approach. So you take the cues from the client, more open-ended discussion. And again, you want to match the style or approach to the task. So where this might be appropriate in a healthcare context is perhaps when the individual's received bad news, or you've had to deliver bad news, they need an opportunity to kind of process that experience with you. And so then you'd want to do more reflective, open-ended, validating response to their experiences. Or when there's potentially a grieving process happening. Directing. So there are times where it's appropriate to step in and kind of take charge of a situation. These are probably more likely to happen in high urgency, high emergency situations where there's potentially safety issues involved. You might take more of a directive approach there. And guiding. So this you could consider on one end of the continuum a following approach or style. The other end, a more open-ended, a more directive approach, taking charge, and kind of somewhere in the middle of that continuum is what they call within motivational interview the guiding approach. So it's kind of a blending or a balancing of the two. And so typically you'd use this guiding approach when you're having those difficult or critical conversations about behavior change, so the more challenging, complex behavior change. And so it's especially important then to use that empathetic, accurate empathy, active listening approach. And then within those types of general matching of communication style to task, you can also look at some more general communication in terms of active listening. I'm going to go back to a little more detail around that in a moment. Listening. Now, listening is something that I think it's easy to view as being pretty straightforward. I think we all like to think we're good listeners, but there's always, I think, opportunity to improve upon that. And it's actually more complicated than it can first appear on the surface. So just invite you to keep that in mind. And informing, and of course informing is communication. We typically, I think, in healthcare tend to deliver a lot of information-based services. And it's important to look at how are we conveying that information to our patients or the people we're working with in a way that they can understand and take in that information and being able to put it into practice in their lives, or actually understand and make value of that. So see how that fits in and the rationale in taking action for them. So within active listening, and some of this comes from stages of change. Are you familiar with stages of change as well? Yeah. And so kind of things that you want to be mindful of or attending to. So anytime you hear I should, I wish, I want to. So this would be either you could view this as preparatory language. So people are thinking about making a change, but maybe not quite there yet, or sometimes they talk about this as a component of change talk within MI. And so supporting those individuals to shift that language towards more a commitment to change. So I will, I'm going to. Some micro skills within motivational interviewing. I believe Stasha had touched on this in her presentation a couple of weeks ago as well. So the idea of open-ended questions. Okay. Generally around kind of the what and the how, although sometimes why questions are appropriate as well. Just want to be a little bit cautious with that though, because sometimes they can, depending on how they're used, can promote a kind of a defensive reaction. So always important to be attending to or mindful of what is the response that you're getting from the individual you're working with. Affirmations, so again, affirming that inherent self-worth of that individual. Reflective listening. And within that, of course, always the opportunity to reframe their experience so the individual has a sense of hearing their own words or voice ideas reflected back to them, and summaries. So again, within motivational interviewing, we would always encourage this to be done within the context of the relationship. Bill Miller talks a lot about the spirit of MI. So staying in the moment, and that this staying in the moment or this attending to the relationship can be a very powerful mechanism in and of itself for change for that individual. Something that we call non-specific factors in change of healing. And then also being mindful or looking ahead to responsiveness to what that individual is bringing forward. So this just outlines some of the stages of change. I'm not going to go into any detail there, but just acknowledging that it's important to match our approach with the stage of change or the readiness for that individual. Again, to support the likelihood of the opportunity for them to take action and experience success in the changes they're making. So we talked a little bit about what works with therapeutic relationships, and this is just some reminders about what the literature, the evidence shows doesn't work so well. So confrontation. So a lot of the research actually around the confrontation issue comes out of some of the addictions literature and research, and in particular Bill Miller's work. So one study that his research team had looked at was within alcohol treatment, and what they found in interviewing the interactions between the clinicians and the patients, because at one time there was a bit more of a directive or almost confrontational approach to treatment. And what they found is that the more the clinician told the client what to do, the likelihood of their drinking, the number of drinks they would have in between sessions actually was correlated, it went up. So for the frequency of the number of times they were told, you got to stop drinking, don't do that, look at the impact it's having on your life, that kind of an idea, they actually increased the likelihood of them drinking. So not the outcome we're looking for. Negative processes, again, that's pretty straightforward, but those are kind of critical blaming comments. Assumptions, so it's important to clarify. We think sometimes that we have a good understanding of where people are coming from or what they're thinking, but actually if you look at the literature, we aren't always very good judges, and so it's important to actually ask. Rigidity, so you want to have some flexibility in your approach, try and provide them with options from which they can choose, so respecting their autonomy. You want to avoid something that we call the ostrich, so it's pretty straightforward, but the idea, not sticking our head in the sand, so even though we see an inkling of maybe something's not working very well, and we just kind of hope that it's going to go away on its own. It often doesn't unless we're actively addressing that in the context of our work. And not assuming that one approach fits all. So this is kind of acknowledging the contextual nature of the work that we're doing. And so just because an approach fits for one client or patient doesn't mean that that's necessarily going to hold true for everybody that we're reading or looking at. So within that, understanding that sometimes you may hear comments like this coming from patients. And so an indication that something is off, potentially in the approach or the relationship, or that they're encountering a barrier. And Pam is going to go into some more detail around that later. So I can't see why I need to change. So this sometimes gets framed as denial. Important to keep in mind though, Bill Miller talks about how we have a tendency in healthcare, an unproductive tendency to sometimes blame the patient. And so the reverse of this is, the patient might come in and say, I can't see why I need to change, and the response is, well, we're in denial. And so just an invitation to notice that denial is often a response that comes up when people are feeling threatened or pressured in some way. And so it's a natural human tendency. I can see what you mean, but, so this would be an indication that that individual is likely, again, an MI, what they call ambivalent. So kind of two minds about changing, not sure. And so there's an opportunity then to kind of explore those two sides, or alternatives with them. Just tell me what to do. So traditionally, people have the expectation that we're the experts and we're going to tell them what they should be doing. And sometimes that can be appropriate within the context of the relationship, but always important to check in and say, but how will that work for you? So again, it's that collaborative approach and responsiveness. And I really can't cope at all. So this is a real red flag that something's off. The individual's feeling overwhelmed, and so we want to take a step back and see where is their place of readiness. Are we moving forward into kind of planning and goal setting and they're not ready to go there? Is there just so much going on in their lives, lots of barriers coming up, and it's they're feeling overwhelmed and perhaps low sense of confidence. And so how can we be proactive in managing some of these communication styles or contexts within the relationship? we want to, in setting the stage early on in our work with clients or patients, we can minimize or increase the likelihood that there'll be a strong relationship, being clear in our expectations, what are realistic expectations. Carlene's going to talk a little bit more about expectations in a moment. And we have the opportunity then to minimize the risk of misunderstandings. So be clear what our role is, what expectations we have around what treatment or services we're able to provide, what we can't. And then let them know what our expectations are for their role. So sometimes people will come in with a more traditional view and feel that not necessarily have the perspective that they need to be active participants, especially again when we're looking at making sustained lifestyle changes over the course of a lifetime. Proactively clarify expectations for both patients and providers. It increases the likelihood of patient success. Again, it's demonstrating our respect for their own autonomy and supports them to take a more empowered, active approach and builds their confidence and self-efficacy. And increases ultimately engagement in treatment. So I'm going to turn it over to Carlene.
So do you want us to ask questions now? Or do you want us to ask questions back?
If there's a clarifying question, I can take that now. But if it's more kind of a broader discussion-based question, I'd actually, it'd be great if we could hold that for the facilitated discussion.
Any clarifying questions before?
I can start.
So I know that within a primary care environment, you're being able to see patients with many different conditions for many different reasons. And weight might be the reason they're coming to see you. It might not be. It might be something that you're identifying as an issue, but it's not maybe the reason they're coming to see you or any of this. There's a lot of different places where weight might be easier to talk about, less easy to talk about. And so I wanted to kind of look at maybe some of those conversations and those critical conversations that either you get say you walk into and you don't realize you're in a critical conversation in the moment, kind of like you've stepped on the landmine, or the conversations that maybe the patient has identified yet around weight that you're going to try to have those questions and try to bring the subject up, or you're getting asked some pretty challenging questions and you're maybe not exactly sure how to answer it. So what we find we often hear from clients and trying to figure out is, well, what is a healthy weight? Did everybody get that one? Have a good, clear answer on that? It's a bit of a loaded term, right? Healthy or normal. That can really mean a lot of different things. It could be a height and weight table, many different pieces. What should I weigh? What should you weigh? What's the right weight? Is your weight the right weight for me? Is the right weight that I see on the magazines, is that the right weight? Is the right weight the height and weight table? What reference are you guys using? So that's all. It seems like a simple question, right? You go to your healthcare provider, well, what should I weigh? You should be able to just tell them, right? Not an easy question. And then you start talking about the goals and like that, and I thought, well, you know, I was 140 pounds, and then you ask when, grade 9, that was my lowest weight, felt really good at that weight. You know, you're talking to someone who's 63. So you start looking at, okay, maybe they did feel good at that time, but is that realistic, achievable? Maybe not. How can I do it? I'm coming to see you as a dietitian, we get this a lot. Okay, what's the plan? Give me the sheet. I want to lose the weight now. I've got that wedding coming up in July, and I need to look great. And it's got to be now, fast, go. Then I tell them it's about 10%. You know, I can probably get you maybe 5% by July. They're like, what? What's with that? No. Okay, well, all right, I agree to do that. We'll start. But then what? So that's a bit of a hard conversation. They come back to the follow-up and they say, I did everything you said, fell into the book, doesn't work. I only lost 2 pounds in the last week. So what happens there when you've got, actually from a clinician, I'm thinking everything worked, and the client's going, this isn't working, and they stop everything. So you got some differences there too. Or, yeah, I tried that program, it was awful. I did it for a whole year, I only lost 20 pounds. And so what do? They stopped doing it. I hear this a lot when people are doing programs like Weight Watchers or Jenny Craig's or something like that, that they really feel that they gave it a lot of work and a lot of effort. Like if they put it in for a whole year, right? That's a lot of work to do for a whole year, attending meetings every week. The outcome that they got wasn't what they wanted or what they felt would be a good outcome, so then they stop. But then as a provider, I'm looking, saying to somebody, okay, if you were 200 pounds and you lost 20 pounds, it worked great. So we're not viewing the outcome the same way. And so that can be one of those critical conversations that you have to have. And that's what we're going to look at a bit of the evidence. What about this one? My doctor sent me to see you because I need to lose this much weight, which is very high, to get, I see everybody nodding, so you must have got all the referrals yesterday or something. Yeah, I got to get my hip fixed. I need it to be able to have a baby. I need it to be able to do, in specialty clinic, when I worked in a specialty clinic, it was to get transplant. Like if not just to go to the wedding now, we're looking at people who are really getting very significant barriers to the next important stage of their healthcare. They can't get an MRI, they can't get a CAT scan for cancer diagnosis, they can't get proper care, health insurance, travel. There's really significant barriers related to the BMI and to their weight and to their health. And so the doctor sends them to the dietitian to be able to get the 100 pounds off, to be able to get them to their surgery. How many people feel that's reasonable, achievable, right? It's so tough. So then you've got that critical conversation starting right there with your client. But that girl on TV lost 160 pounds in 4 months. Why can't I? Especially when they come to see me and they know that I'm a professional. So I should be able to do better than things that are on TV, right? Better than what they can read in the magazine. I can do better than that. I can probably get them more weight, faster, better. Great. Anybody want a job? Yeah. So expectations are really, really high. And the challenge is that the evidence-based outcomes, and we're going to look at that today, are lower, not only than what patients want, but they're lower than what we want. I would love to be able to have a client come and see me, say, oh, you need 100 pounds for your hip surgery? No problem. Here's our plan. I know exactly what to do. Let's get it done, because hip surgery is a great thing. We're going to move and walk in fantastic. Guess what? I tell my clients, even with all the work that you can do, and you're awesome at your life job, and I'm awesome at my job, guess what? Can't do it. So now what are we going to do? You know, we want permanent weight loss. Everybody wants to know that the treatment that they provide to their client is actually going to work and it's going to treat, right? I'm not going to look at giving you a medication for blood sugar if it might work and it might not work, and well, it's going to work, but only going to give you like maybe 2%, and it's only going to work for 2 months, and then it's going to right back, right? That's really frustrating as clinicians. We want to be able to come in and really find those solutions that will work for people. And it's a real struggle because the amount of work and effort that the client puts in to weight management is completely off the chart compared to the outcome, right? And think about it as clinicians. How much time do you spend with clients trying to help them with their weight and their weight management to be able to get no weight gain or 10% weight loss, right? Doesn't it feel like the amount of work and effort you put in, you should be able to get the 100 pounds and get them into hip surgery? Like, wouldn't that be, that we want that kind of big reward too, right? Because, yeah, we're great clinicians, look what I did, right? It's rewarding, it can be, right? And we don't reward ourselves when people don't gain weight. We don't reward people when they did their journal for a month, right? That's not gonna make a headline. So it's really hard when we have expectations of the patient, the provider, but also of programs too, right? Because we know there's operational demands, there's demands as far as for staffing levels, there's program guidelines of how many patients you can see, how many visits you've got in a day, how long you can spend with the client. Those are realistic barriers and support. So we have to look at the whole piece. So where do we get these expectations? Where do we get these outcomes? So how much time, let's say in a year, would you spend with a client talking about weight or weight management? So if you think about one patient, I did the math for me when I was working in specialty clinic. I would probably, at the whole time for a whole year, maybe work with somebody for 4 hours. I can spend an hour a day with Dr. Oz. And then if I didn't get enough time with him, I can go online. I can get direct emails all the time. The internet, multimedia, etc., it's full-time 24 hours 7. The amount of exposure is really, really significant. And what happens is, where do we get our expectations of what's possible? If you look at the outcome with the People magazine on the left, very, very popular magazine, really big distribution. They have an annual issue for the half the size issue. Annual. There's a whole feature in there, and that's under the health and wellness section. And so what they're doing is featuring people who, with lifestyle, they didn't use surgery, they didn't use pills, to lose at least 50% of their weight, and featuring them on the cover. You'll find that you end up with programs like Biggest Loser, right? I know you get a lot of people coming in, I have people who, why can't I do that? Why isn't that isn't helpful? And if you look at her weight loss, she actually lost 60% of her body weight. 60%. It's really significant, and there's a lot of backlash too, as far as for when she came out, her weight, you know, her BMI was like 18, and people were really scared. As a clinician and as a dietitian, I was like, but wait a minute, like she lost 155 pounds. The BMI 18 wasn't the red flag. That wasn't the, oh my God. That was an oh my God a long time ago, right? Like there's some pretty significant problems. If you're exercising 5 hours a day and eating less than 800 calories a day, even for one day, that's really significant, right? And so that happens is that these images are on the media, and it helps people, especially the times that maybe they're tired and they're watching TV and they're struggling, to think that this is a norm and that this is okay and that this is where I should be. And if I'm only losing 5%, but she lost 155 pounds, like what am I doing wrong, right? The other thing too is, if you look at, what about for weight regain? If you look at what happened with Jessica Simpson, if you look at her on her left, okay, to put this in perspective, she's 16 there. Okay, so we don't have that number there. So this is a pediatric image, correct? 105 pounds. Then we have a woman who's now 6 months post-delivery, woman, post-delivery. How much does she weigh on the right? Because she's being called fat, obese, and being ridiculed for her weight gain, let herself go, she's got all these food phobias. How much does she weigh? What do you think?
25. She's not that big.
She's 125 pounds. So how distorted is our images if she's getting bullied for her weight because she went up to 180 pounds with her pregnancy and then back down to 125 pounds after, and being on the cover of many magazines being told she's fat. That's very distorted, right? And so the challenge is when we look at our categories and you're trying to figure out what's normal, right? So we've got to work against all those medias and all those conversations, and that's a really important conversation, critical conversation to have with your patients is, what are they seeing as normal? What are they reading? What are they looking at as influences to think about what they should be doing and how they should be perceiving themselves and their successes and their challenges? One of the big challenges with this is, I know we're all familiar with the height, weight tables, BMI, etc. This is a big challenge. The label that we use for that range is normal. Who here doesn't want to be normal? Another one that we see is healthy. Who doesn't want to be healthy? I've had clients say, but I understand that, you know, my BMI is 55 and I need to bring my weight down. I can bring it down 10%, but that means I'm still obese. I don't want to be obese. I want to be normal. I want to be healthy. And so it just even the labeling that we use in medical literature, not just in the media, we can actually find that could be having people reading that, especially in the height weight table, and figure where they're at. This is how the BMI has been determined about where we are as far as for the healthy range. And what's interesting is that a lot of people use the height and weight tables or a BMI to determine a healthy weight and a weight loss goal. And that's actually incorrect. The BMI range is a disease risk tool. It's going to give you an indication for mortality based on a ratio of your height and your weight. Your lowest risk for mortality, for death, not even for disease, for death, is in the lowest range of that J curve, so you're 18.5 to 24.9. It does not mean that if you have a BMI of 55 and you get down to 25, that you've decreased your mortality. What's interesting is that this data is actually based on some data from 60s to the 80s. And now if you look at the current data, this curve is flattened out a bit because you're actually finding that the people who are in the BMI of 25 to 30 do not have increased mortality. So your overweight category and your quote unquote normal weight category have the lowest mortality rate based on weight.
So it's really interesting to see where the data goes. And that's where you'll find people want to be in the lowest risk, but it doesn't mean if you're at the higher risk and you go down that you've improved. It just means wherever you are today, that helps to determine your mortality risk. And that's what you'll see too with Dr. Sharma's data that he worked with Dr. Padwell. You see where that risk level goes. And this is the NHANES data that they looked at, and looked at the EOS scores and compared it across time. People who have a BMI of class 1 obese, so greater than 30, if they have a stage 0 on the EOS scale, guess what with their mortality? It doesn't really change up to 250 months. Where the big problem is not so much how big you are, but how healthy you are. The more health conditions you have, the more severe those health conditions are, that starts affecting your mortality. So even if you look at the stage 3s and stage 2s, even if you're at class 3, class 2, normal overweight, so if you're unhealthy yet still a normal weight, you've got increased mortality. So that's another important piece to have with that critical conversation with your patients. It's not just about weight. It's about how healthy you are, not just how big you are. And having them understand that piece. Because not necessarily bringing the weight down is going to improve their overall mortality risk. So it's a really important piece when you're looking at setting goals and talking to your clients. We often have people coming in and asking us, how much weight can I lose, how am I going to do? But that's the second phase. And we've got to look at first keeping the weight the same. I always tell my clients, if we had met in your 20s, and the only thing that we were able to accomplish over 10 years was that you were the same weight in your 20s, would that be a goal that you would value? And they're usually in their 40s at this time. They're like, oh yeah, for sure. Because I was only 220 pounds when I was in my 20s. Now I'm 450. Okay, so then that tends to help them understand the value of quote unquote doing nothing. Keeping the weight the same. It's a lot of work and effort for all of us. If we could stay the same weight in the next 5 years, in the next 10 years, that's a lot of work and effort. And we have to recognize and value that and put that into our planning. Then we can look and see, okay, is weight loss indicated here? And if so, setting a realistic, evidence-based, appropriate goal for the intervention that you're doing and an appropriate rate. So let's look at some evidence. If you look at Yulin's paper, which is an excellent paper, I can send the PDF if you're interested. What they did was they did a systematic review and meta-analysis of all the different interventions and then pooled the data to see what the outcomes were. And what you'll find is within the first 6 months of a really intense intervention, 5 to 10%, pretty much everybody's doing. So it doesn't really matter whether people are doing a program like a Weight Watchers or a Jenny Craig, if they're just reducing their calories, if they're doing calories and exercise, if they're doing behavior therapy, throwing in a medication, you're looking at that 5 to 10%. What's important to know and look at is in the long term, so 2-3 years later, what happens? And you'll see that every single intervention has weight regain. We all make that assumption that we're going to lose the weight and then keep it off. But is that supported in evidence? It's what we want, but is there evidence to support that? No. The normal pattern is to have some regain. But what do people want and expect something different? They did a great study where they looked at over 6,000 people, and what they wanted to look at is, they did a question and said, okay, for this next weight loss attempt, realistically, what do you think you could be able to lose? And then ideally, if you could have any number you want, what number would you want? And so what they actually found was that the expectation, or that what's that realistic, was pretty bang on to what actually could occur. It was always within around 8%, so it was within that 5 to 10%, so that's good. So that really helps to reinforce, at least from my perspective, that some of our patients really could be reframed and to kind of know where that realistic expectation is. But look at where ideal is. 16%, 12%, up to 20% with lifestyle. That's really what they truly want, and that's really high, and not achievable with lifestyle intervention at all. And you'll find the higher BMIs, younger age, and females had the highest ideals or goals. And so that might be something to kind of look at and having those conversations about what people are expecting to happen and maybe what they really, really want, and trying to look at conversations around that. When you're looking at surgery, and I know a lot of people get questions about surgery and about what happened. This is really the outcome data that we would expect from, let's say, what we'd expect from bariatric surgery. And if we look at the pooled data of all the outcomes, you'll find people lose about 20 to 30% of their initial weight, total.
That's it. That's not to start, that's not in the first 6 months. So you're looking at somebody for whatever day they're starting surgery, about 1/3 of their body weight. It's not 100% of their excess weight. It's not all of their normal weight. They're not getting to normal BMI. And so that's important to have people understand and frame that. And what we're really looking to do is, if you can look at some good clinical outcomes, they can get below a BMI of 35. There's really good evidence for mortality and morbidity related to 35. It's not to get to 25. And that's just some of the pooled data as well, where you find, because obviously different procedures provide different outcomes, but you'll find that on average, about that 50 to 70% excess weight loss, most people are losing at about, in the pooled data, 14 BMI points. So really good clinical endpoints as far as for weight. But realistically, if a patient is expecting to lose all of their weight or get back to 140 pounds that they were in grade 9, that's not realistic. And we need to be able to provide them some discussion and evidence around that. So it's important to talk about the outcome and about weight loss. Important to talk about all of those pieces. And what's really part of the critical conversation is actually having this conversation right at the start and getting a strategy and a plan for prevention of weight gain, for weight loss, getting back again to stability, and preventing regain, and helping people with those phases, because really the weight loss phase is a very small piece of it. Just to show you as far as for some outcome data with lifestyle, there are people who are going to be able to lose some weight and keep it off, but you'll find that it's a very small percentage. In some of the bigger studies that are actually like a structured program and supervised and monitored over time, you have about 20% who can actually lose 5 to 10% and keep up to 5% off over 2, 3, 5 years. So it's not that the Jareds of the world don't exist. They do. They're just not that common. And what we often have people doing is comparing themselves to the case study, comparing themselves to the exception, and not actually going with what the norm is. Their experience is actually very normal and very, very common, but they feel like it's wrong because of the media, because of all the expectations. And you'll find that most people will regain 30% of the weight that they actually lost by the first year and have it all back within 5 years. So lifestyle is good to a point, but it has limits. But so does bariatric surgery. 20 to 30% are not going to get to those initial markers that we talked about, like looking at 20 to 30% of the initial weight, below the BMI of 35, etc. And some people are going to experience regain. You'll find about 20% of the total weight that they lost tends to come back. And you can actually find that it happens around that year 2 to 5. And I would say from a primary care network perspective, that's the clients that you're going to be seeing, because by that time, they're usually completed with specialty care and are being managed and followed within the primary care environment. So the more clients that have bariatric surgery within the primary care environment is going to be seeing more challenges and discussions and counseling around weight regain for sure. So we often hear too, clients coming in, they want to lose 25 pounds. That's a very common goal, or say whatever pound. But one thing to talk about that critical conversation is to maybe help to reframe that, is this actually a goal or is this more an outcome? And what it really is that weight loss is an outcome that results from many different components, and behavior changes can be part of that. And so we want to help people to reframe that the number really isn't the measure, it's the behaviors that you do to do that. So kind of looking at the behaviors, like for example from nutrition, if I had somebody who's drinking 2 liters of regular pop a day, that's contributing a lot of calories. Making some options to look at changing that behavior can reduce the calories, which then could reduce the weight to get to that outcome. But the focus is on the behavior, not just the number. So when we're talking about those critical conversations, really critical that both you and the patients have the correct information around weight and weight outcomes. Definitely, this is new area, new research when we're looking at outcomes. So make sure that you're kind of in the literature, keep up with the most current data available. And it's based on data, not based on current media, etc. Because I know we get a lot of exposure to that, especially too, like all of us can go in and Google and find a lot of information. But is it evidence-based data? That's different. And really, most important, I think, is keep in context of the whole person. I know right now I just spoke about weight itself, but that really kind of burns me because I know it's not just about weight, it's about a lot more. So you want to be able to keep that in context of the whole person. And really reflect on the care that you provide. Other than weight, what's important to the patient? What's the true goal? Is it for function? Is it to get to surgery? You know, is it for quality of life? Because usually there's a reason why you're trying to make a change in your weight, but the weight itself isn't the sole change, and you want to look at those motivators and supports underneath. And how you're going to define success. You should never use a weight change as a marker for success for patient, provider, or program. There's way more outcome measures to be able to look at for that. So that ends the weight section of our critical conversation. We're going to move now to Pam, and she's going to talk more about some of the barriers. And just in the interest of time, because we want to make sure we can get to the facilitated discussion, because I think that's going to be really, we can talk a lot of pieces about that. If we can hold questions until after, I think that would be great. So I'll go with Pam. Thanks everyone.
All right, so I'm going to kind of wrap things up a little bit, talking a bit about barriers. I know I'm in OT, so I'm stepping a little bit out of that zone a little bit today, but I think no matter what profession we practice, in whatever practice area we practice in, we all encounter barriers. I think with our work with patients, and our patients of course encounter barriers too. So you might see a recurring theme. Have you heard this? So these might be some of those sort of red flag statements you might hear. Maybe you yourself have even said some of those statements, but it might be a good indication that there could be a barrier that's impacting readiness, importance, or confidence in terms of behavior change or managing goals for patients. We know that life happens, circumstances change over time. So looking at how our patients' goals are fitting in with their current life circumstances is important. So I think that kind of reinforces that one size doesn't necessarily fit all in terms of approaches or ways of communicating with patients. There is a lot of different types of barriers people might encounter in weight management. These are a few of them. We might be able to identify these right off the bat in our first visit with a client. Some of these barriers might come up later on as patients are kind of moving forward in their weight management journey with behavior changes. There might be a barrier that may not necessarily be as straightforward as improving some of their skills around planning or needing to reset a goal to be a little bit different. There might be something else that needs further assessment. We really need to think about what's impacting our patients' ability to engage in behavior change and how we can enable them to move forward. So a couple of examples of this. For someone, we'll call her Connie, I guess. She talks about increasing her physical activity, for example. And so some barriers that could come up for her sort of in the first visit before you even set a goal and you're starting to talk about physical activity might be, well, I work in an industrial area. There's no sidewalks. I feel self-conscious about walking in my neighborhood. So all those things might come up before you've even set a goal. Or you might have someone else named Connie who has been working toward her goal. She's got a fairly specific goal in terms of walking on her lunch break at work, and then all of a sudden her schedule changes, and all of a sudden she's got lunch meetings, or her workload has changed, or she had to take a leave of absence from work. So all those things can come up along the way as well. We probably know this, but just to reinforce that mental health medical conditions and even medications can impact our ability to make changes and even manage in our day-to-day lives. So just keep in mind that if some of all of these things are affected by whether it is medications, medical conditions, or anything related to mental health, it's important to get further assessment of some of those issues, because if someone is just struggling to get through some of their day-to-day activities, it can be really hard to initiate new behaviors into your life as well. That's something I really talk about a lot as an OT, so I kind of injected a little bit of that in there. Going back to the 4 M's of obesity might help you to be able to identify some of those issues that might be a little bit harder to pick out right off the bat. An example of this might be sleep apnea. Maybe you've someone's kind of working on their goals. I'm not sure whether you guys screen right off the bat for sleep apnea. Maybe you do, which is awesome. But maybe there wasn't really any of those flags that came up right off the bat, and then all of a sudden your patient comes to you and said, they don't sleep well, they're tired all the time, they have no energy. And that can kind of go either way. It might cue you to screen for sleep apnea, but it also might cue you to screen for depression. So knowing about some of those screening tools is really important. And of course, there is the Epworth Sleepiness Scale for sleep apnea. That's one screening tool. There's the PHQ-9 for depression, and there is some screening tools for ADHD as well, just as some examples. We don't necessarily have to be the experts in doing those full-on assessments, but we do need to be aware of where we can refer patients for further support and assessment, so that we can make sure they can get back on track. So as you're in your visits with your clients, what are you thinking? What thoughts are coming up in your head? So some of these thoughts might be coming up kind of randomly, which I tried to depict on the slide. And with it, like with every client, whether it's someone we're talking about with weight management, whether they're struggling, whether they're not struggling, all these questions come up, usually pretty randomly. They don't come up in a linear way like our assessment and follow-up forms are designed. But I think if we start to have some of these questions about our clients, it's a really good indication of some of the questions we can actually ask them to see how things are going. We all have those clients, whether it's the first time we see them or the 5th time we see them, and something happens, or they tell us something and we're not really sure what to do. We don't really know where to start. What are our next steps with this client? And it can be really helpful to have some conversations with the team to help organize those thoughts, or have a conversation with one of the other providers that's involved in this person's care. Maybe something came up in the last visit that you didn't hear about, or things like that. So just keep in mind that, I think this is normal for us to organize our thoughts. We really want to support our patients, and I think asking ourselves these questions really help people to be able to ask those questions of their clients and remind them that this is complicated. There's a lot of stuff going on, but finding ways to communicate that back to our clients is important in helping to identify and address barriers. So I think we all know there's a lot of paths we can take towards a goal. So this picture here, this is actually Lombard Street in San Francisco, which is known as the crookedest street in the world. I've been there, I think I was 12. But anyways, so just like our weight management journeys, there's lots of ways to get there. So there's this really, really windy road in the middle that you can walk up, and there's cars that go up and down it too, but there's also these staircases on either side. But there's a process, and there's lots of different ways to do it. So just like weight management, lots of ways to get there. The end is probably going to be different for everyone. So it's really important to recognize that and help our clients to recognize that too. I think that helps support some of the expectation management for them as well. And as Carlene mentioned, our clients spend a much smaller proportion of time with us as their healthcare providers than they do living their day-to-day life. They're the experts in their lives and what their reality looks like, but we can really help them to identify some of the strengths, barriers, and strategies to support their weight management journey towards some of their health goals within their own context of their life. One part of that is reinforcing their circumstances that challenge our ability to change, and that this is normal. Life happens for everybody. It's always in different ways, just like that process of change. And some things we have control over and some we don't. It's really important to focus on change as a process, as a means to the end, but not just the end. But we also don't really want to forget about that end point, whether that's weight stabilization or weight loss for people. We can find ways to manage what we do have control over, and that can help us through some of the barriers. To support our clients, we can facilitate some skill building in stimulus control, problem solving, contingency management to help manage some of those barriers, and support the process of change to achieve the outcomes, but recognizing the process is different, the endpoint is different, and reinforcing that managing any chronic disease such as obesity is a lifelong ongoing process that isn't the same for everyone. So we really like this image. We thought it worked well for helping people to manage barriers, because we know that we always have our plan A. Sometimes we have plan A, B, C. Not always, but plan A doesn't always work. Some of our clients have some thinking or emotional barriers, such as all or none thinking, which can be a bit of a challenge when you want to help people develop different strategies when people are really thinking only about one. This can help us to help patients realize the learning that barriers present. We can work with them to problem solve and get back on track. We can help them to understand that barriers, just like everything else, is normal and expected, and they're different, but they're not insurmountable. We always have our best laid plans, but thankfully there's always another way. So brainstorming a few strategies right off the bat, having sort of contingency plans, plan A, B, C, to work on a goal right at the beginning can give clients some options to work with, even between your visits, because sometimes there might be 4 to 6 weeks between your visits, and if that first strategy doesn't end up working for a couple of weeks, what's the client going to do? So if you give them a couple of options, that can be helpful. Reinforcing that behavior change is a trial and error process is part of this. When clients are experiencing barriers, it's important to reinforce that our circumstances change, but with that our plans need to change. So thankfully there's 26 letters in our alphabet, so hopefully there's a few options there. Being proactive and prepared is part of the behavior change process as well. One of the studies we looked at suggested that it's helpful to manage goals by having a variety of strategies, so all those different contingency plans that might work in different contexts for different stages of change. This might be important than just one strategy, I think, for obvious reasons. So going back to Connie, we talked about how she had a goal around physical activity. Her plan is to walk 10 minutes on her lunch break 3 days a week. So that's a goal that probably fits most, if not all, of those SMART principles everybody talks about. She's got 3 strategies for her goal. So keeping walking shoes under her desk, that's an example of stimulus control. Contingency management is a bit of that use of if-then. So if the weather's poor, she'll walk in the long hallway instead of walking outside. And asking her coworkers to join her is a good example of using social supports or helping relationships. But what happens if she goes on vacation? What's the plan then? So in your visits, it can be really helpful to discuss what potential barriers or challenges could be coming up for your clients in the next few months. So this might be, if you're talking to, if something comes up about summer vacation in your visit in April, it might actually be helpful to talk about that, because depending on when you see them again, some of those situations may have already come up. So even if you don't necessarily go into a full conversation about it, encouraging your clients to think about those situations, I think, can help mitigate some of the challenges that can come up when people are in those situations. Other examples might be, planning for someone with a young family that they're all going back to school in September. You might want to start thinking about what those plans might be in July, or thinking about how people are going to manage Christmas dinners when you see them in November, because you may not even see them until January, so you'll have to find out how things went after that. As healthcare providers, we can support and promote the use of positive processes and help our patients develop strategies to support goals, troubleshoot, or offer a different perspective when barriers come up. So with follow-up and support, it's important to reinforce that behavior change is an ongoing process. It's important for us to reassess readiness and confidence, not just at that initial visit, but throughout our visits with our clients, just so that we can help people to plan for the stage of change that they're at and help adjust their goals if that's needed. We can be proactive in developing strategies to support our goals, so how will we manage challenging situations ahead of time? We can support flexibility in goal setting, so not making goals. It's important for goals to be specific, but at the same time, if they're so specific, they're only going to work in one situation. What happens when something changes again, just like I mentioned. So allowing for that contingency management is important. In a study that we looked at by Norcross, which I know is fairly old now, but when they looked at behavior change in making resolutions, some of the processes that were used for successful change in the 6 month to 2 year mark, so sort of in that maybe more maintenance phase, you might say, helping relationships were one of the important change processes. So that might be professional relationships, or it could be personal relationships. So those professional relationships patients have with their healthcare providers, or their family and social supports. Environmental control to support their goals, and interpersonal systems control. So that's using relationships to help help support your goals and maintain changes as well. So how can we support our client and Connie's success? So these are just a few things. We can acknowledge and validate that weight management is difficult, and I think managing any chronic disease is challenging as it is a lifelong process. No one's expected to get it perfect every day. Recognize how our relationships and communications with our clients can impact processes of change. We can support our clients in their individuality and the process of change and effort. How can we keep the cart on the road when maybe it kind of veers off a little bit sometimes? This can help us and our clients to build resilience and persistence through skill building to manage barriers and challenges, supporting and managing expectations with our clients that our clients not only have for weight but other areas of their health and life, setting up additional supports that are needed, and reinforcing positive behavior changes to support quality of life and help our clients to engage in life activities while on their self-management and weight management journey. And I say this because there's a lot of people that I think they want to get to a certain weight before they do X, Y, Z, but it's really important to help facilitate some of that engagement in what people would like to do at the weight they're at, because there's not necessarily any guarantees. So I think that really helps support quality of life and support living while people are on the journey through their health, as it is lifelong, and really focusing our health and functional outcomes rather than the numbers of the scale is really important. A lot of times, one of the first things our patients say to us is not necessarily related to the number on the scale, unless sometimes if people get weighed first thing. But one of the first things some people would say to me when I worked at a specialty clinic and I asked them how things were going, oh, I feel better, I have more energy, I'm sleeping so much better. It wasn't necessarily about whether that number changed on the scale or not. So it's important to really reinforce those things. So we started with a quotation by a Henry. So I guess we're ending with one by a Henry, a different Henry. But anyways, we wanted to end with a bit of a motivational quotation that could help us and our clients remember what we're striving for on a daily basis. Not necessarily this quotation, but having a visual, an item, something to focus on can help reinforce what we're working toward. To support what we're doing. It's really important for even us as providers to see that every day is not the same. There's always different stressors, pressures, celebrations, sometimes moments of peace. It's important to look at everything one thing at a time, one step at a time, and being realistic given our circumstances. Part of our relationship with our patients is to help them move forward toward their goals, manage expectations, and address barriers. We know they're in charge of managing their condition on a daily basis, so helping to support that's important. Some questions we can ask ourselves, or maybe even ask some of our patients, is what can I do today? So what can I do today to improve my health, to improve my relationship with my clients, my communication skills? What strategies will help me? What will support positive thoughts instead of negative? So our goals might not seem quite as daunting if we look at our resolution or goal for that day, instead of thinking about, okay, I'm going to do this for the rest of my life, and determine how we can work towards it given our current circumstances. So that's kind of the end of our content. I just wanted to bring your guys' attention, which you may or may not be familiar with already, to the CDM Resource Center. It's actually got information on a lot of different chronic conditions, so if you haven't looked at it, there's quite a lot of information on it. There is a page specific to obesity. So there's a lot of resources on there. There's a link to a page about our team, the Provincial Bariatric Resource Team, some opportunities for provider education, including a provincial webinar series that our team hosts the first Wednesday of the month. The next one is on bariatric surgery, so there's information on that website about that. A document of a list of the high capacity weight scales in the province, so that could be quite helpful. And nutrition guidelines for health professionals, so adult, pediatric, and there's bariatric surgery guidelines. Just a quick reminder that we will have an evaluation emailed to you guys, so that will come from probably Jody. So if you, in the next day or so, if you could take a chance to complete it, that would be great. Our team is looking for feedback just to help improve our presentations. So I think, does anybody have any questions about the content? I know we're getting